In case of uh, GI bleed, the whole GI tract is divided into upper tract and lower tract by ligament of Treys. The anatomical landmark for this ligament is duodenojejunal junction. So now there are various causes for upper GI bleed, but today we are gonna focus on three types of main causes: esophageal causes, gastroduodenal causes, and miscellaneous causes. In esophageal causes, there are many, but the important one is esophageal varices. In the gastroduodenal causes, peptic ulcer, erosive gastritis, carcinoma stomach, gastric antral vascular ectasia, angiodysplasia, or vascular malformations. And in other causes, we have hemobilia, hemosuccus pancreaticus, coagulation defects, etc. This gives us the broad view of all the causes that can lead to GI bleed. But the four main causes, according to Harrison, is peptic ulcer, which accounts for more than 50% of upper GI bleed, esophageal varices 2 to 40%, Mallory Weiss tears, and erosive diseases. Um, so can you take thoda niche?
Yes, yes, sure, sure.
I have briefed here about the four main causes. In very few words, we're going to study about peptic ulcer in the next sessions. But related to GI bleed, one thing that we have to know is the source, that which artery is most commonly bleeding in which type of ulcer. So, as we know, in peptic ulcer, there are two types of ulcer: gastric ulcer and duodenal ulcers. In the gastric ulcer, the most common source is left gastric artery, and the most common site is lesser curvature of stomach. But in duodenal ulcer, the source is gastroduodenal artery, and the most common site is first part of duodenum or a duodenal cap. One thing that is of significance is the anterior duodenal ulcer. They mostly tend to perforate, and the posterior duodenal ulcer, they mostly tend to bleed. Now, there's an image that I have attached below the ulcer. So, can you zoom in on that?
Yes, yes. The peptic ulcer image on the left, right?
Yes, sir. Now in this image, we can see that both dono ulcers, they have given the endoscopic images. In the gastric ulcer, we can see the base is very smooth and fibrin covered. So uh, it shows both anterior and posterior duodenal ulcers. When the ulcer is present at the same site, anteriorly and posteriorly, it is also known as kissing ulcer. Then the next disease, which is common, is erosive gastritis. Now, when there is any type of stress on the body, like trauma, burns, raised ICP, if the patient is on ventilator for a long time, it causes to produce increased amount of prostaglandins, and which leads to formation of ulcer. So, can you take down thoda?
Yes.
Like as I've said, if there's stress on the body, it leads to increased production of prostaglandins, which leads to erosive gastritis. Now this is relatively non-complicative disease which can easily be treated by pantoprazole. One thing that is important is if the ulcer is due to burns, it is known as Cushing ulcers, and if it is due to raised curling ulcers, and if it is due to raised ICP, it is known as Cushing ulcers. The next cause is esophageal varices. We all know that esophageal varices is a complication due to portal hypertension, but It occurs when the hepatovenous pressure gradient is more than 5 mmHg, and the bleeding in that varices occurs when the uh, pressure is more than 12 mmHg. In the gastric peptic ulcer, we've seen the source is left gastric artery, but in the esophageal varices, the source is left gastric vein. And the the bleeding, it occurs due to development of systemic collaterals. Also, one thing that I've mentioned here is the leading cause of portal hypertension. In adult, it is alcoholic or non-alcoholic cirrhosis, but in children, it's extrahepatic portal vein obstruction, which the most common cause of this is umbilical vein catheterization. The last and very non-threatening disease is Mallory-Weiss syndrome. It is basically just a submucosal tear, a tear in the submucosa. It can be due to alcohol binge drinking, hyperemesis gravidum, which can both lead to retching, and the patient can present with hematemesis. And this also the source is left gastric artery, and the site is gastric site of gastroesophageal junction. As you can see in the image, longitudinal mucosal lacerations near the esophageal gastric junction. Uh, sir, uh, uh, and the table they were the two things that were mentioned were Delafoy's lesion and Hades syndrome. This Delafoy's lesion, it is basically a diagnosis of exclusion. Like if we can't peg any disease, we think of this. Basically what happens is whichever artery is present in the stomach, like supplying stomach, it is present on the serosal part of the stomach, but due to some vascular malformation or anything, this the in Delafoy's lesion, the arteries, they are present in the submucosal area. So there can be punctate erosions due to enlarged submucosal artery. Then there is Hades syndrome. It presents with a classical triad of aortic stenosis, bleeding, vascular ectasia in colon, and acquired von Willebrand disease. Uh, the small intestinal sources are vascular ectasia, Delafoy's lesion, malignancy, NSAIDs, and one which is very important is Meckel's diverticulum. It presents with rule of two. It is 2 inch long. It involves two mucosas. It is 2 feet from ileocecal junction. And in the scan, we used to see this Meckel's diverticulum. We use technetium 99 per technate. Sir, clinical features.
Is it visible? Clinical features?
Yes, sir. So basically, in the causes we've seen, whenever we'll write the causes for upper GI bleed, we'll mainly divide it into gastric causes, esophageal causes, and duodenal or small intestinal causes. And if we can write miscellaneous causes. Now, these were the causes of the disease, but how will the patient present with? The, the patient usually presents with hematemesis or melena. As we all know, hematemesis is vomiting of blood. The color of vomitus depends on either the duration of blood in the stomach or severity of bleeding. Like uh, if there are red vomitus with clots, it indicates that that there is
Kushi, we are not able to hear you. Kushi, we are not able to hear you. Is my voice audible?
Maybe I think we have lost Kushi. Her
I think there
voice
might be
and
an internet
is not good.
problem.
Okay. Okay, okay.
So maybe
I
by the
will try.
time she's coming, I'll just
Yes, yes.
give you an overview of whatever she
Sure,
has
sure,
dealt
sure,
with.
sir.
So primarily, whenever we are thinking about upper GA bleed, we are thinking about any bleed that is above the ligament of Treves. And clinically, whenever we are approaching an upper GA bleed, our question is basically whether it is a variceal bleed or a non-variceal bleed. So that is how our approach to upper GA bleed is. So primarily because the management is entirely different for variceal bleeds, and for non-variceal bleed, there is a plethora of different types of management that we can. I'll just give you a brief on once all the pathologies has been discussed. So our primary question is whether it is a variceal bleed or a non-variceal bleed. And under the non-variceal bleed comes your ulcers. Ulcer can be a peptic ulcer disease or it can be even a malignant ulcers. Then there are other conditions like esophagitis. Then there are abnormal vessels or AV malformations like your duodenal lesions or angioectasias. Then there are very innocuous reasons like a malarious tear where there is primarily trauma or any rich-induced injury to the mucosa that can result in bleed. Now, there is an entire class of pergeal bleed which can be easily picked up by the history. That is your corrosive ulcers or corrosive bleeds. So that is again another set of pathologies that can result in upper GI bleed. So grossly, you can divide it into variceal, non-variceal, and under the non-variceal comes your ulcer bleeds. Under the ulcer comes your peptic ulcers as well as malignant ulcers. Then you have your esophagitis, angiectasias and duodenal, then malarious, and rarely your corrosive esophagitis. So now coming to the variceal bleeds. So what we do is whenever we are coming across a patient with variceal bleed, our question is always on the age of the patient. So in a younger individual, adolescents, kids, the variceal bleed is because of an extrahepatic portal venous occlusion because it's a disease of adolescents and kids. And as age increases, your uh, other pathologies like your cirrhosis and cirrhotic hypertension, portal hypertension bleeds come into picture. Now, again, there can be uh, like under cirrhosis, again, alcohol is one of the pathologies. There can be also non-alcoholic fatty liver disease. There can be also chronic hepatitis B or C associated liver diseases. So this is how your variceal bleed and its classification goes along. So, and again, like, there are certain pandas or there are certain commonly asked questions that you need to know about. One is about Cushing's ulcer, another is about Curling's ulcer, burns and Curling's, then raised intracranial pressure and Cushing's. So that is how you associate. It can be common questions that you might get in your NEET exams. So, is Kushi back online?
Yes, sir,
Yes,
she's
sir.
back. Can I
Yeah,
just
yeah,
put
yeah.
one
So
question
we
here,
can
sir?
go ahead. Yeah, sure, sure.
Sir, the ulcers that come in the stress states like sepsis or otherwise also like we see in ICUs when the patient is admitted with
Yeah.
severe infections or patient has a hypotension.
Mm-hmm.
These patients usually in
Mm-hmm.
terminal stages they develop a very massive upper GI bleed, and
Yeah.
previously
Yeah.
they were non-cirrhotic and their liver function was also normal. So these are
Yeah.
also stress ulcers, sir.
Yeah, that they are also stress ulcers. Yeah.
Okay, okay, sir.
Yeah.
Kushi, I will share the screen again.
Yes, sir.
I have put it in the clinical features part.
Okay, so we were at clinical features. The two main features present, the patient present with is hematemesis and melena, but there can also be hematochezia, but that is mostly a feature of lower GI bleed. And the sir, can you go a little down for a image that I've shown in the clinical feature?
Yes, yes, yes. Is this the one
The
or
source of no, below that source of bleeding, heavy bleeding, light bleeding. Okay, so this the color or the appearance of vomitus or melena, it is so useful that based on the features of that, we can classify whether that it was upper GI bleeding, lower GI bleeding, heavy bleeding, or light bleeding. Like as we, if the patient presents with coffee ground vomitus, it is usually due to upper GI bleeding, but the bleeding is light. But if the patient presents with dark red blood in the vomitus, it is upper GI bleeding, but the heavy bleeding is there. Or similarly, uh, in the melena, we can see that the stools, they are black, tarry, foul-smelling, bulky stools, and they also show positive fecal called blood test. And apart from this two main symptoms, hematemesis and melena, patient can also present with variety of different symptoms. Based on the associated symptoms, we can pin down the cause of gastric bleeding. In the upper table, I have shown that. Uh, sir, ऊपर uh, if the patient presents with the features suggestive of peptic ulcer, like if the patient is presenting with epigastric pain, the pain is aggravating or relieving based on the food intake or whatever the features we have for peptic ulcer, we can pin down the cause of upper GI bleeding as peptic ulcer disease. But if the patient is presenting with liver disease stigmata, that is jaundice, pedal edema, abdominal distension, splenomegaly, ascites, dilated abdominal veins, or even spider nevi, palmar erythema, jaundice, or gynecomastia, we can for sure say that it is due to variceal causes. If the patient is presenting with alcohol or unsafe ingestion, trauma, burn, or sepsis, it is due to erosive gastritis. Heavy alcohol intake or vomiting, it is due to Mallory-Weiss tear. And if the patient is presenting with weight loss history or dysphagia or a mass or tenderness, it can be due to malignant causes, stomach, esophageal cancer, or intra-abdominal tumor. So, one more important thing is that if the patient has an acute episode of bleeding, the patient will present with intravascular depletion, uh, like dizziness, extreme pallor, or in shock state. But if the patient has chronic bleeding, uh, he or she can present with symptoms of anemia. So, based on the associated symptoms, we can pin down the cause of upper GI bleeding, and we can also say that if the episode was acute or chronic. Uh, so, that was about clinical features of upper GI bleed. Now, when we'll go for the assessment of upper GI bleed, we will assess an assessment. It We have to look for either the history, in which physical examination signs, or the investigations, or what the investigation shows. In the history, we have to look for vital signs, orthostatic hypotension, like if the patient is dizzy or dizzy, hypotensive, and all. Abdominal tenderness, skin and oral examination, stigmata of liver diseases. We also do rectal examination, like objective description of stool, like, or assess if there's any mass or hemorrhoids in the rectal area. In investigation, the most simple investigation is CBC. Will look for decreased RBC, hemoglobin or platelet. Will also look for blood, urea, nitrogen, and creatine. Uh, if the blood urea nitrogen is increased at a greater extent to creatine, it is usually a sign of severe bleeding. We also look for LFTs to show if there's any chronic liver disease. Uh, then there are in the upper GI bleeding, there are various scores that assess whether the patient needs to be hospitalized, or a patient needs any urgent endoscopic therapy, or what is the mortality rate in this patients. So can you take a little down? Uh, We also look for prothrombin time and cross match the blood if we need potent infusion. If the patient's HB is less than 7, we often give the infusion because we need the HB hemoglobin to be around 9 at least. As I was talking about the score, the most important score is Glasgow Blatchford score. It basically predicts the need of hospitalization in this patients based on 9 parameters, that is blood urea, nitrogen, hemoglobin, systolic blood pressure, heart rate, melena, syncope, hepatic disease, or cardiac failure. Like by any chance, if the score of the patient is more than 2, the patient needs hospitalization, and if the score is more than 7, the patient needs urgent endoscopic therapy and ICU. And if the score is 0 to 1, there is no need of hospitalization. Uh, then the other score was AIMS 65. It basically uh, predicts the mortality in this patients. AIMS, the full form is albumin, INR, mental status, systolic blood pressure, age. Like if the albumin of the patient is less than 3 gram per DL, INR is more than 1.5, mental status like GCS is less than 14. Uh, Systolic blood pressure is less than 90 and age is more than 65. This parameters are used to predict mortality in these patients. The next score is forest score. It shows the need of endoscopic therapy, like whether the endoscopy we do in this patient, is it only diagnostic or therapeutic. Like there are 4 grades: 4A, 4B, sorry, 1A, 1B, 2A, 2B. In this grades, we need immediately endoscopic therapy, which is spurting arterial blood, oozing hemorrhage, visible vessel or adherent clot. In this patient, we have to take them for immediate endoscopic therapy. But if we only see a clean based ulcer or a fibrinous coating on the ulcer, we can relatively monitor the patient and plan for elective endoscopic therapy. So, can you take a little down? This was the table that was shown in Harrison, how to deal different types of different causes of upper GI bleed. But I guess before going through this table, we'll discuss the broad medical management, and then in the end, we'll revise it with this table. So, again, down. Okay, so whenever a patient presents with upper GI bleed, first thing we have to do is medical resuscitation and replenishment of intravascular volume. Like we have to provide an IV access, fluid resuscitation, blood products transfusion. Like if the HB is less than 7, we have to maintain it above 9. And if the patient is presenting with active bleeding and platelet count is less than 50,000, we have to transfer platelets. And if the patient has a history of coagulopathy or its prothrombin time is increased, we have to give fresh frozen plasma infusion. Uh, then we have to do the initial clinical assessment of the patient, like its clinical status. Like we have to observe for tachycardia, hypotension, any sorts of dizziness or shock symptoms. So down. Then we have to check if the patient has any liver disease or comorbidities like cardiovascular, cerebrovascular, respiratory, renal comorbidities. Because when we take this patient for endoscopy or surgery, it can worsen the acute bleed. Then if we are in previously, when we used to treat upper gastrointestinal bleed patient, we used to do gastric lavage, but it is not done in the present day. Because gastric lavage, it carries the risk of aspiration. It does not really affect any mortality in the does not really affect in the mortality numbers. And we have better techniques nowadays like endoscopy. But the gastric lavage was it had advantages, like it helped it It used to help localize the bleeding site, type of material, whether there was red or coffee ground appearance, assess rate, severity, persistence, and recurrence of bleed. Also, clear blood from stomach for better visualization. Remove blood, uh, which decreases encephalopathic risk in liver diseases. Dilute acid pepsin, decrease blood and erosion, and minimize the risk of aspiration. But nowadays, we not really go for gastric lavage. We directly go for endoscopy. Uh, if the before endoscopy, we have to give some pre-endoscopic pharmacotherapy to the patient. If the cause is non-variceal upper GI bleed, we go for IV PPI infusion, 80 mg bolus, and then 8 mg per hour drip. Most commonly uses esomeprazole. The rationale is we have to decrease the acid in the stomach and facilitate clot formation and stabilization. Like we have to stop the acute bleed and the risk of recurrent bleeding. Uh, in most of the patients, early endoscopy within 24 hours is recommended. But if the bleeding is relatively light, we can also go for elective endoscopic therapies. But in the endoscopy, the procedure is first we give the epinephrine injection that basically causes vasoconstriction of the area, which decreases bleeding. Then hemostatic clips that fix the bleeding vessel, and we also thermocoagulate that vessel. But as we know that duodenal wall is very thin, so we have to be careful when we do thermocoagulation, because we have to prevent perforation of duodenum. But after endoscopy, we also have to look for post endoscopic pharmacotherapy, in which we sir um, upper right side. In post endoscopic management, we the if the patient like for 72 hours after endoscopy, the patient should receive PPI, because we have to maintain the intragastric pH less than 6 or more than 6 or 6. We have to determine the H pylori status in all ulcer patients. We have and if we are discharging the patient, we have to prescribe them PPI once or twice daily. Then in patient with cardiovascular diseases, we if they're on low dose aspirin, we have to restart it as soon as possible, as soon as the bleeding has resolved. We have seen three diagnostic scores in upper GI bleed, but we also have a prognostic score, that is Rockel's score. In the score, it considers various factors like age, shock, comorbidity, diagnosis, endoscopic stigmata of recent hemorrhage, and decides the prognostic percentage in this patient. One extra mild thing was we also give pro motility drugs before performing endoscopic therapy, like erythromycin, to provide better visualization. And if the patient has the history of alcoholic cirrhosis, and it is presenting with ascites, there is very high risk of spontaneous peritonitis. So we also prescribe or start the patient on antibiotic. And if the patient has portal hypertension or the cause is variceal cause, then we have to also uh, like give the patient octreotide and trip terlipressin. If the patient is known cause of if the cause is variceal cause, uh, because we have to decrease the portal hypertension, which can, if the portal hypertension is if the hypertension has increased, then it can exacerbate the variceal bleed in the patient. So on the broad view of summary, if their patient is presenting with upper GI bleed, it can either be we have to give conservative therapy, then the definitive management. It can either be due to variceal cause or non-variceal cause. In the non-variceal cause, we directly go for endoscopy, in which we do vasoconstrictive epinephrine injection. Then we human thrombin or fibrin glue. Then we do thermal heat coagulation, and then we clip the bleeding vessels with the help of hemostatic clips. Others, we can go for interventional radiological procedures, transcatheteral arterial embolization, or explorative laparotomy. But if the patient is presenting with variceal bleeding, we have to go for medical management, pressure technique, angiotherapy, and surgical intervention. That is, we have to give vasopressor agents and treat that variceal bleed. Endoscopic variceal ligation and vasoactive medication. Below, I have shown the difference between upper GI tract bleed and lower GI tract bleed. Uh, like superficially, we can say that the site of bleeding is above the ligament of trace, and in the lower GI bleed, it's low below the ligament of trace. But the clinical presentation, if in upper GI bleed, is mostly due to hematemesis or melena. But in lower GI bleed, hematochezia or rarely melena. Hematochezia is fresh red blood in the feces or stool of the patient, whereas melena is black type stool, because if the cause is upper GI bleed, it's mostly due to the action of digestive enzymes. The blood, it gets digested, and then it's presented in the feces. Then if if we did a gastric lavage in this patient, the nasogastric aspiration shows blood. In the lower GI tract bleed, it shows clear fluid. Bowel sounds are hyperactive in upper GI bleed, but they are normal in lower GI bleed. And blood urea nitrogen creatinine ratio, it is increased in upper GI bleed, but it is relatively normal in lower GI tract bleed. The variceal bleeding, I think it will come under the portal hypertension if we'll discuss about that. But one statistic that I wanted to mention here was from one third cirrhosis patients. From all the cirrhosis patients, one third developed variceal bleed, and one third initial bleeding episodes are fatal. Uh, and among the survivors, one third will rebleed within 6 months. So there are only one third survival chances if the patient is presenting with variceal bleeding. This was the chart. If we have to for the algorithm to for the patients with acute lower gastrointestinal bleeding, I this is when we are looking for lower GI bleed causes. So can you go to that Harrison table which we skipped before?
Yes.
This table greatly simplifies everything that we have studied right now. Like if we know that the cause of bleeding is ulcer, we have to look for endoscopic features. If it has active bleeding or visible vessel, we go for endoscopic therapy, intensive PPI therapy, clear fluids, and hospitalization. But if there are only other adherent clot, we may consider endoscopic therapy, PPI, clear fluids, and hospitalize. But if the patient is presenting with just flat pigmented ulcer or a spot, there is no need of endoscopic therapy. We give PPI once daily, clear fluids, and hospitalize. And if the ulcer has clean base, then also we don't need endoscopic therapy. PPI, regular diet, discharge after endoscopy. If the cause is variceal esophageal varices, we have to do endoscopic ligation of this varices, vasoactive drugs like octreotide and terlipressin, clear fluids for 2 days, and hospitalize for 3 to 5 days. In Mallory, we stare. If there is active bleeding, we have to give endoscopic therapy. If there is no active bleeding, there is no need of endoscopic therapy. We have to give antiemetic agents if the nausea persists. There are fluids and hospitalization in the case of active bleeding. And if the cause is due to erosion, then we don't need any endoscopic therapy. We can directly start PPI, regular diet, and discharge as soon as endoscopy is done. So that's it from my side.
Do you want to talk on those images that you told me to share previously?
Yes, sir. Yes.
I've shared the photo image.
Yes, sir. These are few images that were there in Davidson's. The first one is basically it shows endoscopic view of this if of the ulcer, if there is any active bleeding, or in the C photo of the endoscopy you can see there where the hematostatic clips are attached, like how they've treated the ulcer. And the next photo, the stomach, it just broadly gives idea of the causes of upper GI bleed. And the next one is rock call score. I have covered it in very brief, but in this photo it shows in detail, like if the score is 0, 1, 2, 3, 4, or severe, like how the prognosis changes. One also, the I wanted to talk about the difference between hematemesis and hematosis. We know that how to differentiate it, but just for the sake, like in the case of hematosis, there is coughing out of blood. In the hematemesis, there is vomiting of the blood. This presents with sputum. This is present. It is mixed with food particles, and the associated symptoms are also different. So we can easily differentiate between hematosis and hematemesis. That's it, sir.
Thank you. Sir, could you add on to the
Yeah, sure.
points?
So very comprehensive presentation, Kushi. Like you have covered almost everything and touched upon all the important scores and everything. So I'll just come from the symptomatology. So commonly, yeah, you're right till that almost all cases of upper GI bleed will present with melena or hematemesis. And melenic stools are dark colored stools. But one thing that you have to keep in mind is that sometimes an upper GI bleed can present with hematochezia also. There can be two scenarios where this can happen. One is a massive bleed where the blood does not get enough time to get in contact with the acid in the stomach. In such conditions, only if the acid in the stomach gets in contact with the blood will the acid hematin be formed. So acid hematin is what gives it the black color or the tarry color. So sometimes the bleed can be very fast and very massive, and the patient might, instead of presenting with the hematemesis or melena, it can present with hematochezia. Then another scenario is that the blood itself is an irritant. So in upper GI bleed, often you will find in one of the tables you have just mentioned that the bowel sounds are hyperactive. So the irritant blood itself will increase the contractility. So that can result in hematochezia rather than melena or hematemesis. And one important thing is that often your hematemesis is because the blood in the stomach acts as an irritant. That is why it is getting vomited out. And that is regarding the symptomatology. And regarding the different scores, one thing that you have to like filter out how to use which score. So almost all of your scores that you mentioned, like AIM 65, uh, your Glasgow Blatchford, all those are pre-endoscopic scores. That is, without the need of an endoscopy, you can stratify the patient and whether that patient need to be admitted or not, whether the risk of mortality is there or not. So that is all your scores except ROCAL score. ROCAL score has got two parts. One is it can be clinical ROCAL score, which where it can be used for admitting the patient, and another is a complete ROCAL score where we are also using post endoscopic values. So the post-endoscopic values will help us to know if there is a risk of rebleed or not. So whenever somebody is asking you which score will you be using to assess the risk of rebleed, you are using a complete ROCAL score. All your other scores like AIM 65, Glasgow Blatchford, all those are uh, mostly for risk stratification rather than mortality assessment and risk stratification rather than rebleed risk. Now, regarding one important aspect of risk assessment using an endoscopy, that is your forest classification. So forest classification is only for your ulcers. So depending upon the different forest classes, you have 1A, 1B, 2A, B, C, and 3. So depending upon that, there is a risk of rebleed and lesions or the type of lesions with the maximum risk of rebleed, we have to immediately intervene. So all your 1A and 1B, that is oozing and spurting vessels, have to be immediately taken up for endotherapy. Now, regarding 2A, B, and C, 2A and 2B have got a higher risk of rebleed. So that is why they have to be taken up for an endotherapy. Now, 3 and 2C and 3. So these are having very less risk of uh, rebleeding once an endoscopy has been done. And of that, 2C or hematotic spots, they have risk of rebleeding. So we have to try to do something at the time of endoscopy. And once we have done something, the risk of rebleeding is much, much lesser compared to your 2A and 2B lesions. So that is regarding the forest classification. Now, I'll just touch upon variceal bleeds also. So in endoscopy assessment of the varices also, we have got a lot of different classifications. And the one that we commonly use is called as a packet classification or a modified packet classification, where we are looking at the size of the varices and certain red color signs or certain visual impressions that will tell you that these varices have got a higher risk of bleeding. So, depending upon the size and these red color signs, they can be classified as high risk varices as well as low risk varices. And almost all high risk varices need to be managed endotherapically. So, what are the different methods for managing a variceal bleed, and what are the different methods for managing a non-variceal bleed? For variceal bleeds, other than your endoscopic variceal ligation, there are a lot of other methods also which we can do. And this is sclerotherapy where we inject a sclerosant and occlude the vessels. If all these endotherapy methodologies are not available to you, then what we need to know is that there is something called as balloon tamponade, where we are using certain devices or balloons which can be used for uh, giving a tamponade. So some named balloons are there which you need to know. One is called a Sengstake and Blakemore balloon, which has got two parts. It has got a gastric balloon as well as a esophageal balloon, and we can put it in just like you put in a Riles tube. And once you inflate these balloons, it will cause tamponade locally and will produce temporary stoppage of the bleeding from these varices. Another type of balloon is called as a Linton necklace balloon, where it has got a single large gastric balloon. And there is another balloon called as a Minnesota balloon, which has got both gastric as well as esophageal balloons. So just know these names because sometimes in your entrance and all, you might get asked these questions. So of this, the Sengstick and Blakemore one is the most popular one. Okay. And now, if it is not manageable endoscopically, or if there is no, these bleeds are not managed without any uh, tamponades. So what the certain other devices can also be used for managing variceal bleed. These are called as stents. So stent is a device which you introduce uh, into the esophagus without the use of endoscope, with or without the use of an endoscope. And once you deploy the stent there, that stent will expand and compress the varices and cause stoppage to bleeding. So it's a covered stent that we use. It's called as a Danus Ella stent. So just keep that also in the mind because that's also a commonly asked entrance question. A Danus Ella stent is the one that can be used whenever there is a the patient is compromised and you don't have time for an endotherapy. So that is regarding variceal management. And non-variceal, yeah, of course, you are supposed to be starting the patient on pantoprazole infusions. And uh, again, endotherapy based on the type of bleed can also be considered once endoscopy is available. One more thing is that there are certain newer techniques called as hemospray. The hemospray is something called it's a it's a stopgap method. That is, it's something that will it is a proteinaceous material that we are actually spraying into the esophagus or the ulcer. It will go there, make a coagulum or a coat, and it will produce temporary stoppage of the bleed. So that is a newer methodology that is being available now. It's called as a hemospray. And then there are certain devices called OVSCOs or over the scope clips. So these clips are also devices which you can mount on top of the your endoscope, and you can directly go in and clip this particular wound or ulcers using this over the scope clips or over the scope clips. So that is also a newer device that is available for endotherapy right now. And one thing is all your whether it is ulcer bleed or whether it is variceal bleed, all these patients should initially be started on endotherapy, and you have a window of 4 to 6 hours. So if your patient is hemodynamically compromised, it is not advisable to put in the scope. It is advisable to first stabilize the patient and then put in the scope. So that is regarding your timing of endoscopy. And is there anything else that you want me to elaborate upon?
Thank you so much, sir, for the detailed discussion. I had certain questions. Actually, as we have discussed, major type of patient that we come across in our setting is variceal bleed patients, secondary to
Mhm.
the cirrhosis of liver, and they come with a massive upper GI bleed. Most of them tend to be fatal at times. We do manage it conservatively with blood products, fresh frozen plasma, and octreotide and pantop infusions, and some of them do endoscopy and all. Sir, but another class of patients are those who are on antiplatelet drugs or on anticoagulant drugs. Some of them, because of a valvular heart disease or atrial fibrillation or recent MIs, they come with bleeding, sir, at times. So, how do
Mhm.
we approach these patients with upper GI bleed, and considering the importance of antiplatelet drugs and anticoagulation drugs? How do we stop it before doing endoscopy, or we continue it? What are the guidelines for those?
So regarding the use of antiplatelets and anticoagulants, so always has to be like classified on risk benefit ratio. So whenever we are facing an acute bleed with the hemodynamically compromised patient, we are advised to stop all antiplatelets as well as anticoagulant, explaining the risk. So that is what the guidelines is. But if it is a GI bleed but without hemodynamic compromise, then we need not stop your antiplatelets as well as anticoagulant before endotherapy. So that is what the guidelines is. But in our real practice, we often ask for stopping the drugs because sometimes the endotherapy during the endotherapy it can get a little bit trickier because when the patient is on antiplatelets or anticoagulants, there can be frequent bleed, and these devices and all are not usually like they'll cause some trauma and it will keep on bleeding. So that is a real life practice, but all your guidelines say that unless the patient is hemodynamically compromised, we are not none of the guidelines ask us to stop the antiplatelets and anticoagulants. We can do endotherapy with while the patient is on anticoagulants and antiplatelets. Now, regarding when if there is any hemodynamic compromise, so regarding antiplatelets, we are just asked to stop the antiplatelet. Regarding anticoagulants, if the patient is having severe coagulopathy, then we can actually either go for products to reverse the coagulopathy, or we can use certain drugs like recombinant 7A inhibitors, which can be used for reversing the coagulopathy. So that is some newer drugs that are we are that is available for reversing coagulopathy. For antiplatelets, there is nothing. We have just to stop the antiplatelet if the patient is hemodynamically compromised. Otherwise, continue it. There is no guideline which says we have to stop it.
Okay, sir. Sir, in upper GI bleed, what is the role of non-invasive imaging? Sir, in our setup, we have an endoscopy, but it is available with the surgery department, and they do it only on the appointment basis. However, CT scan are easily available. So, most of the patients of upper GI pathology or lower GI pathology undergo a CT. So, is
Mhm.
CECT or contrast CT
So,
recommended
uh,
for every patient, or they have to undergo UGI endoscopy first?
like what the guidelines is that CT comes only after the scope is, unless the patient is hemodynamically compromised. The patient is hemodynamically compromised and we can't take the patient up for a scopy immediately. Then that is the only point where we are warranted in taking a CCT or a contrast enhanced CT at first. Now, what is our purpose of taking a contrast enhanced CT? That is to get a roadmap of the further management. So, suppose we are finding that there is a arterial bleed, and SECT will help you to find out where the artery is. So your next in line of management is to go in and angioembolize. So only if there is an angioembolization facility available, then there is a point in going for CT and taking up the patient for a contrast CT. Not just for diagnostic purpose. For purely diagnostic purpose, uh, unless the patient is hemodynamically compromised, there is no point in going for a CT. That is what the guidelines and all says. Now, in the algorithm of management of bleed, CT comes like, for example, if your patient is having melena, you are going for your first line of management is upper GI endoscopy. You do an upper GI endoscopy, you don't find anything. Your next step is going for a colonoscopy because sometimes the right colonic bleed also can present with melena. So you do an colonoscopy, you don't find anything there. Now what is left is a small bowel. So to assess the small bowel, we are warranted in going in for a contrast enhanced CT with a delayed contrast. So that is the step where a CT comes into the algorithm as such. None of the your upper GI bleed or lower GI bleed, first line CT does not come into picture unless the patient is having an hemodynamically compromised state and we are planning for a interventional radiology procedure. So that is regarding CT.
Okay, sir. Thank you so much. Sir, regarding varicose bleed, we do continue octreotide and pantoprazole infusion, and then we do after stabilization we do an endoscopy. If we find any varices there, then we do endoscopic ligation. So for these patients, sir, we have to do we have to give PPI prophylaxis? Because in some textbooks they say that PPIs can worsen hepatic encephalopathy. So, how do we manage the complications in these patients, sir?
So what the guidelines is like we are we unless you know the pathology, you can start both. The patient is just pressing with an upper GI bleed, you can start both PPA infusion as well as operated or 30%, whichever is available to you. And once the pathology is identified, then there is no point in continuing the PPI infusion. Ideally, like in my clinical practice, we stop all PPIs unless unless there is an indication for PPI, we don't give a PPI. We give only operated, and none of the guidelines also are corroborating that these findings only. Yeah, we are supposed to continue the operated or 30% even after management. We can continue it up to 72 hours. Up to 3 days, we can continue the operated infusion. Or once you are sure that your endoscopic management of the varices has been proper, we can stop it and switch to beta blockers. So that is what the guideline says. PPA infusion, usually none of the guidelines suggest that we have to continue the PPA. And in real life practice also, we don't give PPA infusions after managing. At the time of time of presentation, yeah, we give a bolus dose of pantoprazole and give a bolus dose of opioid and put the patient on opioid infusion or 30% infusion, and we take the patient up for endoscopy. And once we are finding the pathology is varices, we manage the varices and switch to beta blockers. We are not giving PPA infusion after that.
And sir, oral PPIs should we continue or for
Oral
few days?
PPI, unless there is an indication for PPI, there is a dual pathology, like the patient is also having significant gastritis with the ulcers, then we are warranted in giving PPI. Otherwise, PPIs are often misused, is what we feel. We don't usually start PPI for all patients with, unless there is a definite indication for PPI, no need to start an unnecessary drug. That is what I feel. And that is what the guideline says also. None of the guideline includes PPI in the management algorithm of pericell bleed. PPI is not there among the drugs. Straightforward.
Okay, sir. Sir, also one of the tests that we do for evaluation of iron deficiency anemias or even in a case of GI bleed is fecal occult blood testing. Sir, regarding that, slight confusion is there because textbook mentioned that it is only recommended for colorectal cancer screening, and if it is a positive, then colonoscopy is necessary. So, sir, what is the role of this test, sir?
So one thing is stool occult blood is a very obsolete test, and often we find it as false positive. There can be many empty number of drugs that can mimic the stool occult blood positivity. And if you are trying to include it in any of the algorithms, then probably a lower GA bleed algorithm is the one where your stool occult blood can be helpful. Like again, colorectal malignancy, or it can be even hemorrhoid bleeds. Hemorrhoid bleed also you will find that occult blood is positive, even if the patient is not giving any history of any like definite history of any lobar bleed. It can be positive. So it can be often false positive, and usually we don't usually include it in any of the algorithms. Now, whenever we are evaluating a patient with anemia, if there is a significant iron deficiency, and then we are warranted in going ahead with scopies rather than looking at the stool local blood and saying that stool local blood is positive, so let us do scopies. We'll rather look at iron deficiency anemia and then we go for scopies rather than SOBT positivity. But again, it's in real life practice, almost all of us, including me, we do stool local blood, and that helps us to convince the patient that there is something is going on, rather than just looking at the anemia and deficiency and telling that we need scopies. We often do an extra test to tell them that there is some sort of a GI bleed going on. So in real life we do it, but none of the algorithms say that it is a compulsory test or it is has got any significance.
Thank you so much, sir, for clarification of doubts. And I hope this topic was clear to the participants who joined the session. Unfortunately, we had a very less number of participants today because most of them are undergoing their preliminary exams. So we will, and thank you so much, Kushi, as well, for your presentation. In spite
Yeah,
of not
Kushi,
able
you
to,
prepared like she prepared very extensively. Like whatever stuff she told is like the gist of GA bleed for a physician point of view. So that is what is required for you to write your exams also. And some of those slides regarding the scores and everything, those can be helpful even for your entrance exams. So just keep this in mind. These are the stuff that they keep on asking during our entrance exams. If anybody is preparing for PG or super specialty exams, these things are quite helpful. These scores and how to manage, how to risk stratify and all that stuff.
thank you so much, sir. Sir, we will meet again probably this week, sir. I will just confirm from the
Yeah,
presenters.
yeah, sure.
Whenever the time is convenient for you, we will set up another session, sir.
Okay, okay, sure.
Thank you so much, sir. It was very helpful.
Mhm.
Thank you, Kushi. Okay. Uh, please share your presentation afterwards,
Yes.
Kushi. Thank you. Okay.
Yes, sir.
Good night, everyone. Yes.
Okay, good night, everyone. Good night, everyone.